Good afternoon. Thanks for joining us. We're here live at St. Luke's Hospital, UnityPoint. My name is Jan Kriegel. I'm a nurse with the St. Luke's Orthopedic Unit and the Total Joint Educator. I'm joined by Dr. Jeff Nassif. He is an orthopedic surgeon at Physicians Clinic of Iowa. We are here to talk about joint replacement surgery. It's a fairly common surgery, and it has definitely evolved throughout the years as the replacement of joints and the surgical techniques have improved. If you have a question for Dr. Nassif, we encourage you to post it, and as we will try to talk and answer those questions as they come in and are available for us. So Dr. Nassif, let's first talk about why someone would need a total joint replacement.
I think mostly what we're going to talk about today are replacing shoulders, hips, and knees, and they most commonly need these joints replaced for pain.
Great. So what are the most common joints that do need to be replaced? I think you mentioned that, but elaborate a little bit for us if you could.
Sure. Knees and hips are the most common joints, mostly because they're weight-bearing joints, and the numbers are pretty staggering on the amounts of those that are going to be done in the near future and that are being done now. Shoulders are a distant third, and that's mostly because they're not weight-bearing joints.
Okay, thank you. Tell us a little bit about how you go about determining if somebody needs a joint replacement surgery.
Patients will either go to their primary care doctor or come to see us, and we get x-rays to determine the severity of their arthritis, and then we sort of formulate a treatment plan. And usually we start out non-surgical, and the initial treatments for that include oral medications and physical therapy, sometimes weight loss. 6 times your body weight goes through your hip and knee joint with every step you take. And so if a person loses 10 pounds of weight, they feel their hip or their knee feels like they lost 60 pounds of weight, and it really makes an exponential difference for their pain. Besides the physical therapy and medications, we also try different braces and sometimes shoe wear. And then there's different shots we can try. Cortisone shots, like most people have heard of, and then there's different joint lubrication shots called viscosupplementation that we try sometimes also. When it gets to the point that their hip or their knee or their shoulder has severe arthritis by x-ray and the pain significantly affects their daily activities, and they've tried these non-surgical treatments and those don't work any longer, that's the time we discuss joint replacements.
So what are the benefits of the joints that are used today versus what was offered 10, 20 years ago?
Well, several-fold. We'll start out with the shoulder. All 3 implants are quite a bit better than they used to be. They're lasting longer now. The metals and the plastics that we're using now last quite a bit longer than the ones that we used in the past. They all have new bells and whistles to be used in the operating room that allow us to operate on different problems, where we're able to use the current joint replacements without having to use anything special to substitute for bone loss and ligamentous loss that we didn't have in the past. With shoulders, there was a conventional shoulder replacement where we replaced the ball on the socket, or the ball on the ball side and the socket on the socket side, and that's designed for run-of-the-mill osteoarthritis of the shoulder. In the past, when a person had a rotator cuff tear, we weren't able to do a complete shoulder replacement. We did something called a hemiarthroplasty, where we just replaced the ball without the socket because the rotator cuff wasn't there really to hold the ball in the socket. And those folks got reasonable pain relief, not great function, but not great pain relief either. Probably 6 or 7 years ago, they developed something called a reverse shoulder replacement. And that's called a reverse because the ball goes on the socket side and the socket goes on the ball side. And that's designed for people that don't have a functioning rotator cuff, which is a newer thing, and it really provides great pain relief and great range of motion and really great function compared to what we had in the past. With hips and knees, really the biggest changes that have happened besides the implants is our recovery. our pain management around the time of the surgery has changed dramatically, and the way we progressed with therapy has changed dramatically than in the past. About 25 years ago, just before the time I started here, as you may remember, they used to keep people in traction for a week after a hip replacement surgery without getting out of bed. And that's changed significantly. Now we get people out of bed walking the day of surgery and progress their activities very quickly, which helps to get over the joint replacement and back to more normal activities very quickly.
I remember those days.
They weren't that long ago, and it really is the way we manage post-operative pain with what we call multimodal pain management, with the anesthesiologist giving different pain blocks. We give injections inside the knee and the hip. We also do much more minimally invasive surgery than was done in the past, so our incisions are a lot smaller. There's a lot less blood loss, and as you remember in the past, 25 or 30% of people will get blood transfusions after surgery, and now it's well less than 2%. Not many people are needing blood transfusions any longer, and it has to do with the medications we're giving people and our surgical techniques.
Great. If someone is scheduled for surgery, what can they expect?
Well, several things. Preoperatively, you have a pre-op physical exam with your primary care doctor. If you have a heart doctor or a lung doctor, you get cardiac and pulmonary clearance beforehand. You get a thorough once-over to make sure everything's okay with blood work and EKG. And then St. Luke's has a joint academy where Jan kind of goes over everything with you.
Right. And I sit with each patient before they have their shoulder, hip, or knee replaced. I give you lots of information about your hospital stay, what you can expect before surgery, and then on the nursing unit and the plan to get up out of bed, work with physical therapy, work with nursing to manage the pain post-operatively. We use different types of pain management. We use a multimodal as well. We use different things that are available, like aromatherapy, relaxation exercises, relaxation sounds, and then mobility and out-of-bed activity. Each person does see me in the Joint Academy, and we also I also go over with them a regimen for exercises to do preoperatively. We feel that this does help the strength and gives you a little boost before surgery. How long is the hospital stay for these patients?
That's changed dramatically also. As we said, people used to stay in bed for a week, and then we get them up walking with therapy after that, and their hospital stays were around 2 weeks, just 20, 25 years ago. That's come all the way down to about 1 day now, and the average length of stay is just over a day right now. So most people that have surgery in the hospital are going home the day after surgery, occasionally the day after that. We're also, for young, healthy people, doing joint replacements at the outpatient surgery center. So for young people without significant medical problems, they actually can go home the same day by having that done at the surgery center.
How long do the joints last on an average?
That's a very good question, and we really can't give a person a number for that. They, in general, will last over 20 years now. There are some activity restrictions after surgery, such as they're basically all high-impact activities. No running. We don't like people to jump, like play basketball or things like that on a regular basis. And we prefer people not to carry more than 70 pounds on a regular basis. We let people hike, bike, swim, play tennis, golf, all the low-impact activities, but the high-impact activities you need to avoid. And if you avoid those, they'll last 20 plus years, even up to 30 years sometimes.
Great. And what could the patient expect if their joint would wear out? And what does that mean, wearing out?
You mean the artificial joint?
Mm-hmm, the artificial joint.
Well, artificial joints wear out in one or two ways. Either the metal components can come loose from the bone, or the plastic, which is the bearing surface between the metal components, can wear out. We like to x-ray people's joints every 2 or 3 years the rest of their life, because sometimes we can tell that wear before it causes you symptoms, and sometimes the fix is easier. So if it needs surgery, if it's caught early enough, sometimes we can just replace the plastic, which is sort of like just changing the tires on your car without changing the metal components. and that's a relatively quick, easier operation with a relatively easy recovery. If the metal parts come loose from the bone, that's a much bigger operation where you have to replace the whole thing, and that's a little more involved.
What should patients do, or any people do, if they're struggling with joint pain now?
The best thing to do is be checked by your doctor. Our preference nowadays is to keep people moving, and we like people to walk, and we like people to do activities that they want to do. And if it gets to the point where their shoulder, hip, or knee interfere with those activities, you need to be checked by your doctor. And most times people will go to their primary care doctor and they'll be evaluated, and usually they'll be placed on a medication or sent to therapy, or sometimes they'll be given a shot. When it gets to the point those things don't help you any longer is when they'll usually refer you to see an orthopedic surgeon where we can discuss other treatment options.
Question we had from one of our viewers. We had someone post a question on our Facebook page that's asked, what are options for treatment or surgery if you have chondromalacia, patella in both knees?
So chondromalacia patella is a sort of general term for meaning irritation to the cartilage behind the kneecap. Most people with that problem, their symptoms include trouble walking up and down stairs, sitting in a chair for a long time and then trying to get up. Their knee is stiff and sore for a while, but once they get walking, they do reasonably well for a while. There are different grades of chondromalacia, anywhere from grade 0 to grade 4, the way we grade it. With the lower grades, we sort of treat these as the same way we discussed earlier with anti-inflammatory medications or Tylenol. Sometimes we use braces, which are essentially those neoprene knee sleeves with the hole cut out in your kneecap for support, and physical therapy. And that's really the main treatment for these with earlier grades of chondromalacia. If that doesn't work, sometimes we'll try cortisone shots in a knee, and then depending on the grade, we talk about different surgeries. And then 2 different surgeries or 3 different surgeries are basically knee arthroscopy, where we will go in and shave out any flap tears that you have in your kneecap with an outpatient knee arthroscopy, where we place a little camera inside the knee and basically clean it out. Sometimes with that, your kneecap's not tracking properly, and we'll do something called an arthroscopic lateral release, where we release a tight band that's compressing that kneecap to allow it to track in the knee a little better. With the more severe forms of this, you develop arthritis behind your kneecap and can develop something called patellofemoral arthritis, where the arthritis is confined to just the kneecap joint. The 2 treatment options for that are partial knee replacements, where we just replace the kneecap joint, or complete knee replacements. There's kind of pros and cons of both of those. The kneecap replacement joint itself is a smaller operation. That's been done for years, and that type of a joint replacement's probably been done for over 30 years. The problem with that, with all the older implants as well as the newer implants, they've been very unpredictable. Some people will do okay, but there are some people that don't do very well with that operation, so it's something you'll need to discuss with your doctor. The more predictable operation is a complete knee replacement. We know that everybody will do very well with severe patellofemoral arthritis with a complete knee replacement. The disadvantage to that, it is a bigger operation. So these are things we usually have you discuss with your doctor to formulate a plan between yourself and their physician.
Dr. Nassif, thank you so much for your time today. Is there anything else that you would like to discuss?
The only other thing I would add are, hip and knee and shoulder arthritis is very, very common. It is something that is very well managed and can be treated. And it doesn't always come to a joint replacement, but if it does come to that, these operations work extraordinarily well. The biggest complaint we get from people afterwards is, why did they wait so long? Because it really transforms your life and gets it back to where you want to be.
It does. I think I would have to agree with that. All right. That's all the time that we have. Thank you for joining us today, and thank you all for joining us as well. We encourage anyone who is interested in learning more about joint replacement surgery to talk with their family doctor or send questions to St. Luke's at stlukeCR@unitypoint.org. Thank you very much.